Okay, well, let's get started. I think people may be trickling in late. It's raining here in LA. For those around the country that don't know it, when it rains in LA, the whole city falls apart. Weather people are on TV 24/7. Team coverage. Winter storm warning. What happened? Oh, it's raining. Okay. So the freeways are all backed up, and I'm sure people will be trickling in late. Anyways, Happy New Year. I'm excited to be back. Can't believe it so fast. It went. Here we are standing here, starting Farm 2. I hope you had a nice holiday. I did. And you deserve a nice break. But now it's over, so get back to work. Yeah, okay, well, let's start. This is Farm 2, I think you know that. This is going to be identical to Farm 1. In other words, if you turn to page 3 in the workbook, you'll see we're going to do the same thing I did last semester. We're going to have 3 exams during the course, 20% each for each exam. And then the final exam, cumulative, will be 40%. The same thing I did last time. Same books, you got your Farm 2 workbook with you, I hope, first. So that'll be about the same. If you want to take a look at page 6, the schedule. Of course, we're going to meet once a week on Tuesdays, California time at 7 a.m. to 10 a.m. And you can do the conversion across the country. So you can see the schedule. We're going to start off with, in a few moments, muscle relaxants and carry on with that for 3 weeks. Then we'll have test 1. The tests will be no video conference on that day. Test 2 will be the 6th. If you notice, on March 27th, I put in a spring break. That's the time that's a spring break for Cal State universities. That's our week of spring break. I don't think you guys get the week off, do you? I'm not going to have class. Somebody will. Now, I realize, and this happens every year, so I want to say immediately, several of the other universities will have spring break on a different week. And I know that. So whenever week your spring break is at any particular university, please take it and enjoy yourself. You deserve a break. The class that you missed will be, of course, taped and online, so you can watch it when you get back, so that everybody can catch up with each other, depending on what week you're off for the spring break. So fortunately, because the classes are all recorded online, and nobody has to miss anything. But I do realize that during that time, some people will drop off because they were off for the week, etc. Then the final exam will be after the 17th, test 3, and that's about it. Any questions about any of that? Now I want to point out, I'm on the computer here, and this is a website. Let me say it again. You go to Moodle login on the front of our website, kpsan.org. You see on the very bottom it says login as guest. Hit that. It'll be farm lectures. And then anytime it asks you for a password, anytime for anything on this website for my web, it's always pharmacology. So the password is pharmacology. Like so. And you can see here's Farm 2, Spring 2018. And in fact, there's today's class. There's nothing in it yet because we're just starting the recording. I hope, yes. So that's it. So the classes will record, same as last time. Under the resources, I want to point out that, go back to resources. As for password again, of course, it's always Pharmacology. Here's the Spring 2 workbook. You see here the PDF. And so this workbook you have in your hands is also available digitally online. It's in color online if you want to use that. Some people would like to. And then any of the videos, one of these which I'm going to show today, are all here as well. Now, I want to take a second to give a shout out to Dr. Art Hupka, as you heard me mention him, and seen his materials in my workbook. And he's a pharmacologist from Salt Lake City, Utah, and Westminster's program, and he helps me with this class as we go along and so on. And over the break, he very kindly wrote an index for this book. So he indexed the entire book, what's on page what, which is, of course, I'm too lazy to do. I just make you turn the pages until you find it. But he was kind enough to produce an index for this Pharm 2 workbook. And he sent it to me last night, and he said I would be more than happy to share it with anyone who wants it. So I'm going to post it. I haven't done it yet, but when Clinton comes in this morning, I'll ask him to do it. And I'll have him posted under the Pharm 2 workbook, maybe next underneath that. And it's going to say Pharm 2 workbook index. And I was looked it over pretty closely last night, and you did a fabulous job. So you can print that out, or you just have a couple pages to use to index this book. So thanks to Art for his hard work, and for sharing with us as well as everyone who wants it. So that's that. Does anyone have any questions, or did I forget to talk about it? Okay, let's go to page 7. Let's go to work. We're going to do what we always do when we start a new group of drugs. That's just talk about the names. So here's the names of the drugs we're going to do. Page 7. Relaxant Study Guide for 2018. These are the non-depolarizing agents. Of course, pancuronium, which is Pavulon, is still on the market. I hope you never use it. It's a stupid drug. We used to use it when we didn't have anything else, but that was 30 years ago. But for some reason it lingers, and as soon as I say no one will ever give it, somebody sends me an email. Oh, I was in Lincoln, Nebraska at so-and-so hospital, and they had me use Pavulon. So, and it's fine. It's not going to hurt anyone. It's just kind of a dumb drug. Anyways, it's still around, so I'll mention it a little bit, but we're not going to talk about it because I doubt at least the majority of you will ever use it in your career. The ones that are used, of course, I put a little asterisk next to them to note the fact that we actually give them. And that's vecuronium, antracurium, which we don't use too much anymore, cisatracurium, and of course rocuronium, which I would imagine occupies about 90% of the market for non-depolarizing. Mivacurium is a drug that was out for about 10 years back in the 80s, early 90s, and it was kind of a yawn, so wet drug. Wasn't that great, but some generic houses decided to bring it out again this year, so it just got re-released. It's an old drug that we gave up on and didn't use anyways, and for some reason they have some delusion that we're going to use it this time. But, so we'll talk a little bit about that here. Of course, depolarizing, there's only one, that's acetylcholine. The reversal agents and neostigmine, which is paired with either glycopyrrolate, robenol, or atropine, mostly robenol. Adrophonium, which is Enlon, and of course the granddaddy new one, Sugamidex, which is Bridium. So those are the drugs we're going to focus on. There's a couple of miscellaneous I'll mention. Physostigmine, which is supposed to be a wake-up drug, but stupid, so we won't worry about it, but I'll teach you. Phosphorine iodide, which are eye drops that nobody uses anymore, but the cert exam can't let it go, because they learned it when they were in school. So damn it, you're going to learn it too. even though they haven't used the drug in about, I don't know, since I was a kid. They still talk about it. And then the last three, Aricept, Residine, and Exelon, are drugs for Alzheimer's. They have some implications for drug interactions with the anesthetic drugs. So we'll mention those. So that's what we're going to cover. On the next page, starting with the page 8, classification of the non-depolarizers. Well, there's several ways or the relaxants, there's several ways you can classify them. Number one, as depolarizers and non-depolarizers. This is pretty simple. Succinylcholine, because it is acetylcholine. Succinylcholine is essentially acetylcholine. Two molecules stuck together. I'll show you that. Is it called a depolarizer because it causes the muscle to contract or twitch once, just like acetylcholine does. But then there's a period of paralysis while you're waiting for the succinylcholine to go away out of the synapse. So it depolarizes or contracts the muscle once. That's the whole point. The other drugs, non-depolarizers, don't have any contractile properties. They just go to the receptor, block it like a classic receptor antagonist, which we've talked about since the first day of this class ever, September last year. And they just attach to the receptor and block acetylcholine. We can break them up, and that's all the rest of the drugs are non-depolarizers. We can also do it according to duration of action. You notice that we break them up into ultra short acting. I have that here on page 8. There's only one, that's succinylcholine. Short acting, there's only one, mivacurium. Intermediate acting, which is what our bread and butter is, that's atracurium, cis-atracurium, vecuronium, and rocuronium. And there's one long acting, and that's pancuronium. And that's the only one that's left in there. So that's breaking them up according to their effect on the muscle, depolarizer or non-depolarizer, or according to their duration of action, ultra short, short, intermediate, and long. All right, the next page is a little drawing of the neuromuscular junction. You've had this enough to beat to death with every physiology class you probably ever had, starting in nursing school all the way through the anesthesia. And they're just showing a nerve terminal with the acetylcholine receptors. Acetylcholine esterase is the enzyme we'll talk a lot about in the synapse, breaks down acetylcholine, etc. Now, the difference between, I want to mention a couple things. In fact, don't write. Put your pen down. Just let me give you some background about these relaxants. We, on purpose, we conceptualize the human body as having a certain finite number of muscle receptors. It does. All right, it's not an infinite number. You can count how many neuromuscular junction acetylcholine nicotinic receptors there are. I don't know how many, there are millions, but there are. There's a number. So you have a finite number. And what we do with relaxants clinically is we conceptualize everything as to percent paralyzed, percent occupancy. Since this is the occupancy theory of drugs, is the magnitude of response is equal to the percent of receptors occupied. So if you have 100% of these muscle receptors occupied with rocuronium, for example, you got 100% paralysis. If you got 80% occupied, you got 80% paralysis, etc., etc. So I'm going to try to get you, force you, and you will, do what I tell you. No, you will, because this is what we all do. And that is, think of relaxant as percent paralyzed. What percent is this patient paralyzed? Now, there's a couple reasons we do that. Now, one of them is, when I trained back in the 70s, we didn't know that there was a correlation between, well, let me put it this way. We would have patients, and we had curare at that time, and we'd paralyze them, then I'd get to the end of the case, and we'd stop giving curare because we wanted it to wear off. And it took forever to close because they didn't use staples, and they had to sew each individual layer, sub-Q, peritoneum, etc., then skin. So when the surgeon, say you're doing a gallbladder, and the surgeon says, okay, I'm ready to close, you got about another hour to go, right? I mean, it's unbelievable nowadays. So everything's a lap coley, okay, well done, boom, pull out those stroke cards, a couple of little stitches, and they're off to the recovery room. You got about 10 minutes to wake the patient up. Well, we had a long time, so we could stop giving the curare. We'd look to see if they started breathing. We had this, it was a long time. You get the point. So we would try to get the patient back breathing, and then if they got breathing, we said, good, we don't have to reverse them. We took them off to recovery room. Well, then a half an hour later, they're calling anesthesia staff to recovery room, and you're hoping it's not your patient. You're in the back in the next case. You can't leave the room, but you're just hearing all this commotion. And what happened is some patient in the recovery room stopped breathing because they were still tremendously paralyzed. You didn't know it. You dumped them off on the poor PACU nurse, and the patient tried to breathe, but they were still 90% paralyzed, 80% paralyzed. They finally just got tired, pooped out, and stopped breathing. So we had a lot of that going on. We came up with a term for it. We used to call it recurization. In other words, when you turned your back and you left the recovery room, that dastardly curare snuck back on that receptor and re-paralyzed the patient when you weren't looking. It's not your fault. That was the whole point. It's not our fault. It was our fault. But so there's no such thing as recurization, although people still use the term. What it was is we didn't adequately reverse the patient in the first place. And my whole point, or what I'm getting to, is the concept of spare receptors. Spare as an extra, SPA, extra receptors. We now realize that in order for you to have a normal tidal volume and rate, breathe normally, you only have to use 20% of your muscle receptors. You can be 80% paralyzed and have normal respirations. Why? Well, it makes sense. You wouldn't want to design the human body so that any decrement in muscle function, let's say you lost 5% of your muscle function, and then you fall over in a ball and you can't breathe and you die. Or you want to have extra spare receptors around. You don't want to have to use your ultimate muscle strength to perform just the activities of daily living, walking and breathing and talking and whatever. So there's a whole lot of leeway there. You can be 80% paralyzed and have normal respirations, which is what we didn't realize. So we saw the patient breathing, nice rate, nice volume, pull the tube, take him or her to the recovery room. They were still 80% paralyzed. They're breathing against all that muscle relaxant. They're using every possible available muscle receptor that isn't paralyzed with the relaxant. And then finally they just get tired and stop breathing. We realized that you got to have better measures for determining what percent paralyzed the patient is. Hence, neurostimulators, clinical tests, and all the things we're going to spend the next couple of weeks memorizing to have you know that when you get ready to pull a tube on a patient in 2018 in a modern operating room, you know how many receptors are still on the drug, or how much drug is still on the receptors, first day back. And you know what percent paralyzed the patient is within reason. So we can know that we're extubating a patient with, at most, 5% of receptors may be still paralyzed, and that doesn't matter. We even talk about the dose of the relaxants, if you've noticed, and I know you've had people making memorized doses. We limit ED99 of all of the drugs we use, but for the relaxants, we use the ED95. And that's a way to just fool ourselves. We know it's not true, but it's just a way to say out loud, we realize that you don't have to have the patient 100% paralyzed for surgery, okay? So let's look at it this way. Why don't I just walk in and give somebody 100 milligrams of rocuronium right off the bat in the beginning? They'll be nice and paralyzed, won't they? Well, sure. All right, why don't I just do that? Well, because you can't be any more than 100% paralyzed. And you're 100% paralyzed when you use a dose of about 0.9 per kilo, so we'll round it off to 1. Don't be so fussy. So in a milligram per kilo, and a 60-kilo lady, healthy, I give the lady 60 milligrams of rocuronium, I'm going to get 100% paralysis. So why give her 100 milligrams when I can only get 100% paralysis? I can't make any more paralyzed than 100%. You're not going to be more relaxed. You're not going to be better ready for surgery. None of that stuff can happen. You can only be 100% of anything. Right? The other 40% that you gave extra is just going to drive you crazy at the end of the case when you try to get rid of it. Because remember, you got to, your focus at the end of surgery is you've got to get rid of the relaxant to make sure the patient has muscle strength so they can get up and put their clothes on and go home and be happy and healthy. So anything you give extra, yeah, it's easy. Anybody can just give more. But all it's going to do is cause you trouble trying to get rid of it at the end. Whenever you reverse a drug, when you give an antidote to anything, heparin and protamine, midazolam and flumazenil, Sugamidex and rocuronium, whatever, the less that's there, the easier it's going to be to reverse. It's just common sense, right? So the less relaxant you can have when you give the Sugamidex and neostigmine on board, the easier and more reliable the reversal is going to be. And let's face it, at the end of the case, the number one responsibility you have when you wake somebody up from anesthesia is you got to get rid of the paralysis. You can leave a residual opiate on board. In fact, it's a good idea because the patient will have some analgesia. You're blowing off the gas, SIBO, whatever, but you can't get it all blown off by the time you went to recovery room. I guarantee if you measure end-tidal respiration and a patient in recovery room, they're all still blowing off a little gas. It'll go on for a few more hours. But what you cannot do is leave any relaxant around. You have to be 100% right every case for the rest of your career. You've got to have the patient reversed. Because if they don't have muscle strength, they're not going to be able to function. So this is one where we have to be absolute. And that's why we try to only give as much as we have to give to get the job done, 95% ED 95, knowing that then it's going to be easier to get rid of it at the end when we're trying to get rid of it. Does that make sense? Now, all the relaxants produce the same amount of paralysis. In other words, you're never going to hear somebody say, I'm using vecuronium on this liver case, belly case, instead of rocuronium because vecuronium gives you better relaxation. There's no such thing. They all give equal amount of relaxation depending on how many receptors you fill up. If I fill up 100% of the neuromuscular junction acetylcholine nicotinic receptors with vecuronium, or I fill up 100% with rocuronium, I have exactly the same amount of paralysis. So it's the number of receptors occupied, not the drug itself, that determines how paralyzed somebody is. So there's no such thing as better paralysis with one drug or the other. We're all the same. 90% paralysis with Pavilon is the same as 90% paralysis with Nimbex. All right, everybody get that? So why do we pick one over the other? Well, we pick it because of onset, duration, side effects. I mean, they all are going to give you the same amount of relaxation, so why do I give rocuronium instead of cis-atracurium? Well, because they have different onsets, durations, side effects, and some are excreted in the kidneys, so if somebody has kidney disease, you want to avoid that. Some are metabolized in the liver. If somebody has liver disease, you want to avoid that. All the usual precautions that you think of when you pick a drug out of a class of drugs you use for a particular patient. How is it eliminated? How fast does it work? How long does it last? Etc. So those are the considerations. Not a consideration as to how paralyzed somebody is, because they're going to be the same paralyzed if you have the same number of receptors occupied. Okay, does that make sense? Now, what muscles get paralyzed? We're going to go into sequence here in the book in a minute, but just talking off the top of my head. You say to yourself, well, I learned about the neuromuscular junction, And the neuromuscular junction is what controls skeletal muscle in the body. In other words, voluntary movement muscles, kind of things. And the receptors in the neuromuscular junction are acetylcholine receptors, so they're cholinergic. They're actually cholinergic nicotinic receptors, and they're nicotinic sub-M for muscle. So these are cholinergic nicotinic receptors in the neuromuscular junction, and there are two types of nicotinic receptors, N sub M and N sub N. Talked about this last semester. N sub M means N muscle, N sub N means N nerve. So the nicotinic receptors in the ganglia, the sympathetic nervous system, memorized all that sympathetic, parasympathetic ganglia, postganglionic, all that stuff last semester. Those are N sub N. The ones that are in the neuromuscular junction are N sub M. So the nicotinic receptors, we occupy them with relaxant. The patient gets paralyzed and are off and running. Now, realistically, you only have to paralyze somebody when you go into the trunk of their body. When you're going into the abdomen or chest. So procedures that involve abdominal or chest surgery, they have to be paralyzed. Because that's where you need relaxation, so everything inside will lay still, the surgeon can have a friendly operating field, etc., etc. Since much of surgery now is laparoscopic, then you got to keep stuff inside still so they can put the laparoscope and the trocars, cameras, etc. in and do surgery. You don't really need to paralyze somebody if they're having had something above their neck, right? There's no muscles that worry about in the brain. They have neurosurgery. Arms and legs, not really. Doing knee surgery, ankle surgery or something. But you got to paralyze somebody for it. You've been in the operating room for 2 weeks, you've already seen. We paralyze everybody, even if they don't need it. Right? We don't tell the public that, but we do. Why? Cable glue. We don't want the patient to move. This way we can keep them lighter, give them less anesthesia, enough to make them unconscious, of course. But not as much as we would have to give stage 3 anesthesia with SIVO or something. And this way we can wake them up faster. And one of the ways to make sure everybody lays still is just paralyze them. That's easy enough. That's what we do. We just don't talk about it in polite company. So, there you go. Every pharmacology or anesthesia book, mine included, I wrote this in there so I wouldn't get thrown out of the club, always starts the chapter on neuromuscular blockers by saying, of course, these drugs should not replace real anesthesia. You got to make sure you put the patient to sleep and not just paralyze them. And there's the disclaimer that every book has. Right? We all do it anyways. We just don't tell them. Now, what muscles will get paralyzed? You said skeletal muscles. These only work on skeletal muscles. What is that? Well, I think the easier way to look at it is, let's say, what isn't skeletal muscle, and then we'll say all the rest are. Right? I have this written in the book here, but just let me talk. First of all, cardiac. Obviously, cardiac muscle is not skeletal muscle. It would be really stupid to give somebody rocuronium and stop their heart 5 minutes after you gave it, and the case would be over, and it's not a very useful drug. So I mean, come on, even though it's the first day back, we all can agree. You probably don't want to paralyze the heart. Unfortunately, cardiac muscle is different structurally and functionally, so it's not affected by the relaxants. But you say, I keep hearing the cardiac side effects of the relaxants. Yes, there are, but they're indirect. It's because they affect the autonomic nervous system, or they cause histamine release. They do something in the body that's causing that cardiac change. But they don't have any effects directly on the heart. Right? Number 2, they don't affect smooth muscle. So they don't affect the bronchioles. You can't treat a bronchospasm with relaxants. Right? But the larynx behaves as skeletal muscle, keeping your vocal cords open and closed. that golden hole you're trying to find for the tube to go in. That's skeletal muscle. So you can trigger laryngospasm with a relaxant, relax that muscle, larynx, but you can't relax the bronchi. You have to use bronchodilators. Because bronchi is smooth muscle. Right? The uterus. The uterus is smooth muscle. So you can give all the relaxants you want to a pregnant mom for C-section. It doesn't affect the uterus. No relaxation. The bowel. Let's take your GI system from your lips to the other end. All right. The vast majority of it, your esophagus, your GI, your stomach, all your intestines, 40 feet and 45 feet of intestines, that's all smooth muscle. It's not affected by relaxants. The sphincters in the GI system are. So your sphincter between the bottom of the esophagus entering the stomach, gastric sphincter, that's affected by relaxants. That's relaxed. It opens up. That makes the patient susceptible to aspiration. Backing things up, right? Everybody with me? The sphincter going from the stomach into the intestines opens. And then, of course, the sphincter letting everything out at the end relaxes. But the GI system is not affected at all. Well, Johnny, you may say, then why are we giving a relaxant when somebody has a belly case to keep the intestines in? They don't eviscerate, so the surgeon can do, the colectomy or the bowel obstruction or whatever. Well, the answer is this. We don't relax the stuff inside the stomach. The intestines, of course the organs are not muscles, the liver, kidneys, the stomach, the whatever. What we do, and this is the way I'll give you an analogy. We're relaxing the tube, not the toothpaste. Right? The way we're keeping the toothpaste from squeezing out of the tube is we're relaxing the tube. We don't do anything to the toothpaste. You can't squeeze the container, the toothpaste thing. You can't squeeze the toothpaste out of there, can you? Well, we relax all the stomach and chest, the intercostals, all the stomach muscles, the chest muscles are all relaxed. So all your rib cage and your muscles on the outside, they're all relaxed. And because they're paralyzed, then everything inside just sits still. It doesn't have a tendency to push everything out. So again, we're relaxing the tube, not the toothpaste. So we're not relaxing what's inside, we're relaxing the container, which then makes everything quietly stay inside. Right? Make sense? Okay, so this brings us to the next thing. If we're always talking about percent paralysis, then we've got to define what that is. Now, we do that by using nerve stimulation tests, etc. And so I want to go to page 10, and let's start going in this. And what we're going to do for the first little while is we're going to go through all these nerve stimulation tests and some other things and figure out how to monitor and figure out how paralyzed the patient is. And starting next week, we'll talk about the drugs. But before that, let's go to page 27. Let's go to page 27. I may have talked about this table. I may not have. This is probably one of the most famous tables ever done. This was done by Dr. Miller in his book. Unfortunately, he didn't put it in the new edition, which I thought was a mistake. But this was, but he did a lot of his lifetime research on. And so let's start here. And what this is various tests of neuromuscular function. Now, just this week, in fact, the American Society of Anesthesiologists came out with a platform or task force statement saying that anybody, and we're going to talk about this when we talk about reversals, anybody who uses a relaxant should be using a nerve stimulator, quantitative nerve stimulator, one that spits out the percent paralysis on a screen in a digital readout. Yeah, it's fun. It is. We can't even get people to use peripheral nerve stimulator. Right? The number of people that use peripheral nerve stimulator in the real world is probably around 10 or 20%. They're mostly all CRNAs. CRNAs will use it. So if we can't get them to use a peripheral nerve stimulator, it's going to be pretty hard to get them to use one of these more sophisticated ones, because you got to put little things on the thumb to measure thumb movement. You got to calibrate it to that patient every time before the case starts. So it has to be calibrated. There's a whole big procedure. It's not going to happen. So people are trying to promote that, and we'll talk about that later. Anyways, what Dr. Miller did on page 27 on the table is he said, let's look at the various functions people do and see when they get back to normal, how many receptors can you still have occupied with relaxant? So look at the middle column. Approximate percent of receptors occupied when the response turns to normal. This is spare receptors. So he's saying, first of all, let's look at the first one. The test title line. It's the patient breathing. Nice rate, nice volume. You can measure that. We do every second of the case. And what percent paralysis can you still have if they have a normal tidal line? 80%. Is that going to be a good sign to tell you that the patient's reversed? Of course not. It's a necessary sign. Of course you have the patient breathing. That's the whole point. But you got to have a lot more than that to make sure they're not at least 80% paralysis. Single twitch. We're used to talking nerve stimulator, which we're going to go into next. You can have a normal twitch and still be 75 to 80. Train of 4, our holy grail of tests. You can have a normal train of 4 and still be 70% paralyzed. What's up with that? Tetanus at 50 hertz, 70% paralyzed. Good vital capacity, you can pull strongly air in, at least 20 mLs per kilo, 70% paralyzed. DBS, another test on the nerve stimulator, 60. Sustained tetanus at 150. Inspiratory force, 50. Head lift. Been in an OR any more than 5 minutes in a modern operating room? You see all the CRNAs and the anesthesiologists yelling at the patients, raise your head off the bed. Raise your head off the bed. Right. It's a good sign of muscle strength. They can still be 50% paralyzed. So look at the most sensitive test we have. Sustained tetanus at 100 hertz. They can still be 50% paralyzed. Or saying, hey George, raise your head off the bed. They can still be 50% paralyzed. It tells you the exact same amount of information. So we play with those boxes, and I'm going to teach you in gory detail. You're going to hate it. All the different tests and why we do them and so on. But they're no more sensitive than just going, hey George, raise your head off the bed. We don't tell anybody that. Because the surgeons have great gadgets, and microscopes and laparoscopes, and they got all these toys. We want to have toys too. So we play with those peripheral nerve stimulators, and we look like we know what we're doing. They're still there. All right, hand grip. The patient can grab your hand and squeeze strongly, 50%. And sustained bite, they can bite down on whatever, endotracheal tube, airway, anything you try to pull a tube out, they're waking up, they're biting down real hard. That's a good sign of muscle strength, 50%. So, it kind of takes the air out of the sails, doesn't it? All these things that we look for to determine somebody's reversed, and you can still be pretty paralyzed. So how do we differentiate what I'm going to teach them? But anyways, let's turn to page 10. So, Page 10, as I've noted, there's 5 nerve stimulator tests that you can do to determine percent paralysis. And if you let me switch to the camera. Five tests you can do. Number 1, single twitch. I'm on page 10. And by definition, that's a single supramaximal, meaning larger than you need, electrical stimulus ranging from 0.1 to 1 hertz. Almost every box in 2018 just uses 1 hertz. That's hertz. It's in frequency. It's electrical measure of frequency of electricity. It's not hertz. I know that hurts my hand. It's a measure of electrical frequency. 1 hertz. All right. And then we'll talk about the particulars in a second. Now, on paper, the way we show these is they just do a single line. Now, watch my hand move. What we're saying is, this is the patient's hand. Look. It moved once. We show it on paper by showing that line. That's what it means. I hook my nerve stimulator up to the wrist. Dr. Policis will talk about that. I hit the twitch button, and I got this. Excited? All right, next test, trainer 4. It's a series of 4 twitches. That's what a train means. A train is a series. A series of 4 twitches at a frequency of 2 hertz every half second for 2 seconds. So here it is. Half second, 1 second, 1.5 seconds, 2 seconds. Train 4 twitches. I'm showing it here by the 4 lines drawn on page 10. Now, we can number these twitches. We do. It's important. We're going to talk about it. See, I even did it for you there. T1, T2, T3, T4. Twitch 1, Twitch 2, Twitch 3, Twitch 4. And the point of the test is you compare the 4th twitch, T4, how big it is, to the 1st twitch, T1. We'll get to that in a minute. All right, the next test is a DBS, double burst stimulation, and that's 2 short bursts of 50 hertz, so that's a much stronger input, separated by 3/4 of a second. So what somebody did is they said, well, trainer 4 is all fine and dandy, but we don't really use the 2nd and 3rd twitches all that much. Just get rid of them and do the 1st and the 4th, and I'll make it stronger. So they did a DBS. It's kind of a variation on trainer 4. It's just a stronger stimulation. All right, tetanus or tetanic stimulation. This consists of either, nowadays we either use 50 or 100 stimulation for 5 seconds. Now, if you have a nerve stimulator and you look at the front of it, it's going to have a button that says TOF, trainer 4. You push the trainer 4 button once, take your finger off, and the machine, the box, will give out 1, 2, 3, 4 twitches. Right? The twitch button, push that. It only goes if you push it. If you want multiple twitches, you got to keep pushing the twitch button. Right? The tetanus button only gives out a tetanic stimulation, and these are strong, 50 hertz, 100 hertz, and so on. They only give it out if your finger's on the button. It's a safety measure. They don't want it to be accidentally going off under the drapes for 2 hours. The poor patient's hand is wakes up like this or something. So in order for the tetanus button to work, you've got to actually keep your finger on the button. So when you do, somebody says do the tetanus test or do a tetanic stimulation, what automatically means is you got to push that button and hold it for 5 seconds. You got to hold and count 1, 2, 3, 4, 5 in your head. You don't have to do it out loud. So 1, 2, 3, 4, 5, that's a test. You watch for certain things, we'll talk about that. Then finally, so PTC, or post-tetanic count. This was a test that was devised, nobody ever did it, it kind of fell in the wayside, and now all of a sudden it's making a tremendous resurgence with the introduction of Sugammadex, because the company's suggesting that you dose Sugammadex on the PTC count. So I'll teach you how to do that as well. So these are the 5 tests that you can do for nerve stimulation. And so let's move on a little bit and we'll go through. On the next page, this is page 11. I put these in here just so we all have the same terminology. I just want to put it, these are the official definitions of these things. Commonly used neuromuscular terminology, page 11. Bullet 1. What is the onset time of a relaxant? And that's the time it takes from the time you gave it to maximum effect. That's onset time. What's the duration? It's the time from when you gave it to 25% recovery. So this patient's not being extubated, this patient's not being recovered, all right? You still got a long way to go. It's only 25% recovered, 75% paralyzed. But the clinical duration is considered to be the time you gave it to 25% recovery. The total duration is the time you gave it to 90% recovery. And that's the current in vogue number that we use to determine recovery. We say if a patient is 90% recovered from the relaxant, then we consider that the rest of it don't matter. Recovery index is the time it takes to go from 25 to 75. How fast is it wearing off? It's basically what it is. And then the train to 4 ratio is, of course, comparing the first twitch to the 4th twitch, and so on. Now, look at my hand. We're going to do a train to 4. I didn't give any relaxing. Not here. That's ugly. No blotches, really. 1, 2, 3, 4. That's before the relaxant. Okay. 1, 2, 3, 4. That's after the relaxant. How big, percent-wise, was the 4th compared to the 1st?
25.
25? Okay. That's a good answer. I haven't got a clue. But you're right, it may be 25. Let me do it again. I'm just making it up. 1, 2, 3, 4. All right, that's the train to 4 ratio. That's what we do in the real world. You're guessing how big is the 4th twitch compared to the 1st twitch. You're eyeballing it. You're saying, oh, it's 62%. Really? That's why these are called qualitative measures. We're looking at the quality of the response, not the quantity. And that's why these task forces are all going, we need the new boxes that give us quantitative response, accelerotomyography, and so on. So we can say 62%, 90%, whatever. We want the train to 4 ratio to be 90% back to normal. And the way we tell is we kind of look at the hand and see if the 4th twitch is anywhere near the 1st twitch. So it's just a guessing game. It's not all that scientific. But there you go. Okay, now there's 3, on page 11, 3 places you can put the electrodes. Common one, of course, is on the arm and the wrist. And you want to put the red electrode closest to the body, the black electrode closest to the hand. So the red electrode is proximal, the black electrode is distal towards the fingers. electricity flows positive and negative. So when you push the button, the electricity is going to go from the red to the black. If you switch them and put them the other way around, it'll still work. Because this electricity output is so large that it'll kind of overcome. It's just that you look stupid. You don't, it looks like you don't know that you're supposed to put the red first and then the black. So if you want to at least look good in the OR, put the red towards the body and the black towards the hand. And then you stimulate the the ulnar nerve and look at the response in the hand and so on, and we'll talk about that in a minute. If the arms are covered up and you have no access to the patient's head, etc., you can always do the posterior tibial nerve in the ankle, put them on the patient's foot, and watch your toes curl. And lastly, many people like to use the facial muscles on the bottom there, and that shows you the placement of the electrodes. You want to put them just outside the ear, and then you stimulate the orbicularis oculi and other facial muscles and watch the patient wink. Watch it for eye movement. I'm going to trust you've probably done both. Already seen people do this. Okay, let's take a break. Now, I want to turn to page 17 briefly. So page 17, we're talking about what muscles are paralyzed and which ones aren't, etc. So next, let's talk about the sequence. If I'm paralyzing somebody and I'm doing it slowly, let's say I'm giving a drip. We don't do that, but let's pretend. So it's slowly getting the muscle relaxing in there. I'm watching what part of the body gets paralyzed first, next, last, etc. This is what you're going to see. Top of page 17. The first and easiest muscles to paralyze in the body are the eyelids. Eyelids are special muscle fibers because of the blinking mechanism. Of course, they fatigue when you get tired and your lids are droopy and so on. So they have a different muscle structure. They act like skeletal muscle. They're the easiest muscles to paralyze. You may, in fact, when you give somebody anesthesia, if you pre-treat them with a small dose of non-depolarizer prior to giving sucks, which most of us do, then you can sometimes see the patient like trying to keep their eyes open. Their eyes are heavy, they can't open their eyes right. You get double vision just from that little tiny dose of non-depolarizer you gave. So the eyes are the easiest ones to paralyze. Now, that's different than the facial muscles. When you're stimulating with a nerve stimulator, the facial nerve, looking at the eyelid move, I'm talking about the eyelash, your eyelid, not the facial muscles, not your eyebrow. Right, that's different. All right, next is extremities. The next easiest thing to paralyze will be your arms and legs. The next thing that will be the trunk of your body, starting at the top, up your intercostals, strap muscles in your neck, your intercostals down the chest cavity, inner ribs, all the way down the bottom of your ribs, etc. Then your abdominal muscles will be next. Your rectus muscle, your internal and external obliques, etc. The abdominal muscles, they're next. And finally, the hardest muscle in the body to paralyze is the diaphragm. The diaphragm is, again, a unique muscle, different than everything else, because it never fatigues. Thank God, otherwise you wouldn't be able to breathe, right? Diaphragm can't get tired until you're ready to be gone. So it behaves like skeletal muscle, even though it's a special structured muscle. And it's the hardest muscle in the body to stop. That makes sense, doesn't it? Protecting your breathing. When it wears off in the opposite direction. If I just stop giving rocuronium and I watch the patient's recovery, watch it wear off, the first thing to come back will be the diaphragm, because that was the hardest to get rid of, right? Next will be abdominal muscles, then chest muscles, then arms and legs, then finally eyelids. So they go out in that order, they come back in the opposite order. Okay? Now let's go to page 12. We can measure in the ulnar nerve in the hand, the nerve stimulator. We're going to show a movie. I'm going to show you a movie about that and some other things later. Let's talk about the facial nerve for a few minutes. You can measure in the face. A lot of people like it because it's convenient to us. We're right up there at the head. It's just a matter of getting to it. It's pretty easy. It's fairly simple to do. You can use a nerve stimulator with the little metal prongs and just check the facial nerve. And so it's pretty easy, etc. But the point number one is, and let me go on the camera, point to this. Oh, National CRNA Week. Appropriate. You got to put the electrodes next to the ear here. You don't want to put the electrodes up above the eyelid, because then you're sending the electricity directly into the muscle. The muscle is going to contract. If you stimulate a muscle, the muscle can contract, even if you're 100% paralyzed. Because you're not paralyzing the muscle, what you're doing is paralyzing nerve to muscle transmission. You're preventing the nerve from stimulating the muscle. But you're not preventing the muscle from depolarizing if it gets a stimulus from somewhere else, like you're putting all that electricity in it, right? So if I put my little nerve stimulator box here in the eyebrow and push the button, it's going to cause the eyebrow to move. But I'm paralyzed here. So what you got to do is put the electrodes here, and then indirectly do the facial nerve up to the muscle and look at the muscle. Right, so that's number one. All right. Now, look at the bottom, the bolded on page 12. Here's a couple facts. The ubiquitarius oculi response, the facial nerve stimulation, reflects the extent of neuromuscular blockade of the diaphragm better than it does the response in the hand, the adductor pulses, to the ulnar nerve. What they're saying is, now, there's a couple contradictory things, so stick with me. I'll repeat it. If you check in the eye, it's a little closer to what's going on in the diaphragm. What you really want to know is when the diaphragm stops. See, when you're trying to get somebody paralyzed, once the diaphragm's paralyzed, they're paralyzed. That's it. They're done. 100%, 95%, whatever. So what you're looking for, let's say you're doing a rapid sequence induction. And you're going to blast in some rocuronium, and you're going to wait to see when the patient's paralyzed to go down and intubate. You don't want them to cough when you're putting the blade in, etc., or the tube in. How do you know they're paralyzed enough to intubate? You check in your Twitcher box. Maybe. And if you're using the face, that's going to be a better indicator than the hand muscle. The reason is nothing to do with sensitivity, but the face gets a similar blood flow to the diaphragm. In other words, the trunk of your body gets similar blood flow per minute than does the tips of your fingers. It gets less. There's less blood flow to your extremities. So if you're waiting for the drug to get there, remember, this isn't once they're all 100% paralyzed. You're just trying to get the drug to some site in the body. It's going to be easier to get it to the face than it is to get it to the tips of your fingers, just cardiac output-wise. So everybody see what I'm saying? So the sensitivity, forget about that. At this point, when you're looking at onset and you're doing a rapid sequence, and you're counting how many seconds until I can intubate, then you want to look at the facial muscles more than the hand muscles, because the blood flow will be similar. Now, I'll go off on a tangent here for a second. When you do a rapid sequence, a lot of the classic rapid sequence induction is, and we've talked about this before, why are you doing a rapid sequence induction on somebody? Emergency case, correct? Full stomach, you don't want them to aspirate. Vomit and aspirate. When do they lose their reflexes? Well, you memorized all that rapid sequence stuff. It's the most basic question. You're doing an induction. When does the patient lose their reflexes? There you go. And you push the propofol. As soon as the propofol hits and the patient goes to sleep, they're in stage 3, they have no airway reflexes. Then they're vulnerable to aspiration. So the whole point of rapid sequence induction is to keep the time that they're areflexic to a minimum. How do you do that? Well, from the time the propofol is given to the time you get the tube in and blow up the cuff, that's what's going to stop them from aspirating. If you put a physical barrier and a trachea tube in and pull up the cuff, you want that to be as short as possible. So from the time the propofol is given to the time the tube's in. Well, you can't get the tube in until you get them paralyzed. How do you know they're paralyzed? Well, you want to see their diaphragm stop, and then you know they're enough paralyzed. So in a classic rapid sequence, you give the propofol, then you don't ventilate, you sit there because you don't want to ventilate and make them buck, and then possibly aspirate, and so on and so forth. So you wait 30 seconds, 45 seconds. If you're using succinylcholine, usually you're okay by then. Rocuronium a little bit, a few seconds longer. Then you go ahead and intubate. All right. Now, of course, everybody knows that's stupid, because why is all that drama? Oh, don't ventilate the patient. Oh, why would I do that? Because that's what you're paid to do, you dummy. So even in a rapid sequence, we should do a little bit of ventilation. That's what I say. A lot of people refer to it as a modified rapid sequence, and I agree totally. If our job is to ventilate, then please ventilate. If it's me, go ahead and ventilate. I'm not worried about aspirating. So you do some light ventilation. You don't have to squeeze the bag as hard as you can. You gotta have some finesse. That's what we're paid for, our finesse. So you give some light ventilations. You wait. Finally, you think the relaxant is on board. You go ahead and intubate. The patient's protected. So that's the point of a rapid sequence, right? So you need to know the onset of the relaxant. Back to my point. And the way to tell onset best is to look at the facial nerve response, because that's going to get similar blood flow to the rest of the trunk. Diaphragm, larynx, of course, is important, etc. And then you're going to know the patient's paralyzed. If I wait for the hand to be paralyzed, wait for 4 twitches to go away in the hand, that patient's already could have been intubated probably 45 seconds ago. Because I'm waiting for the drug to get all the way out to the fingers and paralyze their hand muscles. Well, they've already been paralyzed here. So you waited too long. And all that extra seconds is time the patient's susceptible to possible aspiration. All right, that makes sense? So let's read my 4 bolded statements on the bottom of page 12. Number 1, the bicularis oculi response to the facial nerve. Looking at your eyebrow move. Stimulation reflects the extended blockade of the diaphragm better than does the response of the hand muscles, electropolysis, when you stimulate the ulnar nerve. Number 2, upper airway muscles seem to be more sensitive than peripheral muscles. One of the big findings you'll see throughout the literature, including my chapter, is that people found out that your upper airway, gag reflex, swallowing, vomiting, we've talked about the airway reflexes before in the oropharynx and nasopharynx, seem to be more sensitive to relaxant drug than maybe some of the other muscles, your arms, your legs, or whatever. So even if the patient looks well recovered, they still might have weakness in their oropharynx, which is a problem because if they vomit, you don't want them to aspirate. So that's one of the last to come back, and that's kind of an annoying, but we can make sure it comes back. Number 3, there's no difference in sensitivity between the arm and the leg. So you can put it on their ankle if you're draped away from the case. Let's say it's a head and neck case, and surgeons take over the head of the table. They put you down at the foot. You can use the patient's foot, and it's the same as using the hand. And finally, number 4, when the temporal branch of the facial nerve is used, negative electrode should be placed over the nerve. In other words, put them over near the ear, don't put them right on the muscle. All right, next place. Page 13. I made this little table then to summarize. Page 13. Monitoring site. The ulnar nerve, abductor pollicis muscles in the hand. What are you looking for? You're looking for the hand to move, thumbs to move, etc. And then what the comments. Usually you have easy access, best site to measure recovery using thumb abduction. Alright, so here's what happens. If you're looking to measure onset, you measure it in the face. If you're looking to measure recovery, you measure it in the hand. There's the best sites. Why? Well, it wears off diaphragm, abdominal muscles, chest muscles, neck, strap muscles in the neck, extremities, eyes. So if your hand is back, the main trunk body part of your body's back, and you're going to be fine. You're looking for a recovery, right? So it's better to measure recovery in the hand and onset in the face. Right? And that's my point. Everybody with me on that? The facial nerve, orbicularis oculi, or actually the corrugated supercilii muscle, you can't tell the difference. Easily accessed when the arm is not available. Best site to measure onset. Okay, let's read what I wrote. Measuring onset. It's now well established that monitoring the facial nerve is probably more ideal than the ulnar nerve when looking for onset. Monitoring the facial nerve gives quicker determination of ready to intubate conditions. Now, if you're just doing a regular case, the patient's already intubated, you just give him some rocuronium for the start of the case, then you can use the hand. You're not in a hurry. Wait 5 minutes, check it, and it's gone, and there you go. I'm talking about when seconds count, you're doing a rapid sequence kind of thing. Right? Measuring recovery there to do it in the hand, that's what that says. Okay. Look on page 15. There's a breakdown of the eye muscles, facial nerve stimulated. There's the orbicularis oculi muscle. And then the bottom one you can see the corrugator muscle is a little higher than the eyebrow. Who cares? Now, in the next look at this, this is onset and recovery. This is the studies quoted here, looking at the eye muscles versus the hand muscles and how they correlate to the larynx, because that's really what you worry about. You want the larynx to be paralyzed so you can put the tube in there without getting this medicine, right? So look at this. This is looking at twitch height versus time, and you give her rocuronium 0.6 milligrams per kilo, and look at the larynx being paralyzed, and then what else? The eye muscles almost follows identically, whereas the hand muscles, there's a lag. So, use the facial nerve for onset, the hand for offset. It's just saying here, here's the hand. If this is back, then these are back too. So, get them both. All right, everybody with me? Questions? Let's go to page 17. Some general guidelines. These are just statements I'm putting out here on how to use a nerve stimulator and what to look for, etc. Kind of generic things. Quantitative monitoring should be used when possible. If you got the right box, we don't, but I have to say that. Peripheral nerve stimulator units should be displayed, delivered current output. During onset, paralysis begins with the eye muscles, followed by the extremities, trunk, from the neck muscles down through the intercostals, then your abdominal and diaphragm. It turns in the opposite manner. Monitoring the facial nerve for onset is preferable. Monitoring offset or recovery in the hand muscles is preferable. Finally, the last bullet, Tactile evaluation of trainer 4 DBS reduces but not eliminates the incidence of residual paralysis. What they're saying is if you put your hand and hold the patient's hand and push the trainer 4 button, if you feel the responses, that's probably more telltale than looking at them. Because eyeballing them is going to be a shot in the dark. You're looking at the hand movement versus feeling it. You can feel if that first one's bigger than the fourth. Just takes a little practice. Next page, 18. Adequate spontaneous recovery should be established before pharmacologic antagonism of the neuromuscular block with anticholinesterase. This requirement does not apply to reversal of sudaminics. So what I'm saying, and we're going to talk about reversal in the third week, 2 weeks from this time, but I'll just mention now. When you go, what they're saying is when you go to reverse somebody with neostigmine, you should have some twitches already before you start. That's ideal. Right? Some people don't care, but ideally you should. With sudaminics, it doesn't matter because this reverses everybody all the time, no matter what. Just give a little bit higher dose if you don't have any twitches, and it'll reverse it. Okay, when there's only one response to the trainer 4, successful reversal may take as long as 30 minutes. A trainer 4 count of 2 or 3 responses, recovery usually takes 4 to 15. This is with neostigmine. 4 to 15 minutes. And when the 4th response, adequate recovery with neostigmine should be able to be held in about 5 minutes, 5 to 10 minutes. When the 4th twitch of the trainer 4 returns, you can do a trainer 4 ratio. Comparing the 4th to the first, when the 4th is 90% of the size of the first, then you're recovered. That's considered recovery. Okay, so let's practice. Page 19. Here's a trainer 4. First one, you haven't given any drug yet. You're just seeing if the box works. So you get 1, 2, 3, 4 equal responses. 1, 2, 3, 4. The hand moved. Oh, we'll do it on camera. 1, 2, 3, 4. Hand moved 4 times, all the same size. You're happy. Box is working. Give a drug. So you'll give your rock or your whatever, and you wait a little bit. And oh, you see the first twitch is starting to get smaller. More, smaller, smaller. All right, that's called fade. You're starting to see fade. The first is bigger than the second is bigger than the third is bigger than the fourth. All right? They're all smaller than it started, so the drug is coming on. There's an onset. All right, if I'm comparing the 4th to the first and calling it a ratio, TOFR, trainer 4 ratio, what would you say the trainer 4 ratio is in this example? How big is the 4th twitch compared to the first twitch, size-wise? Give me a percent. You can't be wrong. 40, okay. This is about half, 40, 50, I'd say, if I was eyeballing it. This is about half the size of this, right? Maybe a little bigger. What I'm really saying is 1, 2, 3, 4. The 4th was half the size of the first when I watched the hand contract. Is everybody with me? So the trainer 4 ratio is 0.5 here, or 50%. You can express it either way. You see some anesthesia records, even the automated ones, some departments actually have TOFR and are running boxes across. When you chart blood pressure, heart rate, respirations, they chart TOFR. What's the trainer 4 ratio? Usually it's 0. If you end up paralyzed, right? Then when it starts to recover, and so on. That's a little anal, but anesthesia departments are anal. So. All right, let's take a look at this. Here's the bread. This is the punchline here. Page 20. I asked a friend of mine to draw this. Thought he did a nice job. And so this is a train of 4 ratio. And what we're looking at is this. So I push the train of 4 button and I get 4 responses, all the same. 1, 2, 3, 4. I haven't given any drug yet, or the patient's not paralyzed yet. All right, that's the start. Now, what I really know, because the train of 4 ratio, test is only sensitive to 70% or less. So really, if I'm at the end of the case and I'm doing a train of 4 ratio and it's all 4 the same, I know the patient's 30% recovered. 70%. Could be 70% paralyzed. I bet they're not, but they could theoretically be. Because it's only a sensitive test up to 70% paralyzed. See what I'm saying? All right, let's say I do this. I push the train of 4 button. I get 1, 2, fading a little bit, 3, fading some more, 4th one's gone. See that? 1, 2, 3, 4th one's flat. 1 response is abolished. T4 is gone. What's a train of 4 ratio? I can't do one because you got to have T4 to T1. So the ratio is practically 0 right now. Right. How paralyzed is the patient? 75% paralyzed. All right, push the train of 4 button. 1, got to get my first twitch. Second one starting to fade. 3 and 4 are gone. How paralyzed is that patient? In the 80s. Train of 4 button, got the first twitch, the last 3 are gone. How paralyzed is that patient? 90s. Push the train of 4 button, 1, 2, 3, 4, nada. Nothing. How paralyzed is that patient? 100%. So I can tell between 70 and 100% how paralyzed somebody is by doing a train of 4 test. Right here, I wrote it down for you, right here. If you get 4 responses, all the same, then the patient's blocked 70% or less, the train of 4 ratio is greater than 90%. That's this one here. 1, 2, 3, 4. If you do 4 responses, and the 4th one is much lower than the first one, then train of 4 ratio is 10%, 20%, whatever, and the patient's paralyzed somewhere in the 70s. Because you got 4 twitches. They're just not near each other. If you get 3 responses, 75 to 80, 2 responses, 80 to 85, 1 response in the 90s. If you're doing anesthesia, you had a perfect ideal anesthetic, you're paralyzing somebody with a relaxant, you would like to cruise during the case for that many hours that the case is going on when you push your train of 4 button to have 1 twitch. The T1, the first one. The last 3 are gone. Why? Because I know this patient's 90% paralyzed. I'm not giving too much relaxant. I'm staying fine lined right where I need to be. But with that little muscle function, 90% paralyzed, is paralyzed enough to stop their diaphragm, and the surgeon's going to be happy and the case is going to be fine. The ideal place to carry somebody is in the 90s. That's what we like to do. It's hard to do. Usually you end up overcompensating and paralyzing 100%. That's just human nature. You don't get into the 90s till you let it wear off. But if I had my choice and of the perfect anesthetic, I want this. 1 twitch, none, last 3. I know the patient's in the 90s, the case is happy, I'm happy, away we go. Keep going. Question?
So for that 90% blockade there, you would expect to see a full strength twitch, it wouldn't just be 1 faded?
It would be, the first twitch would be faded, yes.
Okay, so you would expect that at that 90%, if you're only getting 1, it can still be a weak kind of faded?
Yes, I think it would be more like what I was trying to show here, more like this one. So it's less than full,
Okay.
but it's there.
All right, thank you.
Yeah. Maybe I can ask Steve to open up the handle. Be a little more correct. All right, so you get the point. I'm done. No twitches 100%, 1 twitch 90s, 2 twitches 80s, 3 twitches 70s, 4 twitches but the 3-to-4 ratio is lousy, less than 70%, 70s, 4 twitches, 3-to-4 ratio is greater than 90%. Go back to normal, you're at least 30% reversed. All right, I'm going to say it again. Okay. That was fun. Now, let's do it again. It's just the same thing. I just like to repeat, as you know. Let's look at this. This is somebody, I'm pretending, this is onset of a non-depolarizing. So this is something you've already done in the OR. Somebody gets intubated, put it on me, or whatever you're doing. It's time to paralyze them for the procedure. So you give 30 milligrams of rocuronium since they're already intubated, and you watch what happens. All right, here's trainer 4 before you give the drug. All 4 are equal, big, tall. You gave the drug, wait 15 seconds, check it. What do you see? They're all smaller. There's fade. It starts the onset of the drug. Wait 15 seconds, do it again. Oh, smaller, more fade. What's the trainer 4 ratio in here? 20% maybe? I don't know, guessing. Oh, next one, only 3 twitches. How paralyzed is that patient?
75 to 80%.
3 twitches, 4th is gone. I would say, what, 70s, mid-70s, high 70s? 2 twitches, fade, last 2 are gone. How paralyzed is that patient? 80s, right? Oh, look at this one. 1 twitch, all 3 are gone. That's the promised land. 95%, that's where I need to be. Normally what will happen is you'll end up with nothing. It's hard to guess the exact right dose to get to 80, 95. So then you wait, case goes, 45 minutes later, 50 minutes later, oh, checking my train of 4, ooh, look at this. You get 1 twitch back, then 2 twitches, 3 twitches, 4 twitches. What's the train of 4 ratio in there? So 10%. How paralyzes the patient? Above 70. Oh, here's 4 twitches getting back. They're getting bigger, and finally recovered. It's onset offset. Does that make sense? Oh, there sucks. Let's do that next. All right, now let me explain this to you. I'm going off on a tangent, you don't have to write it down. But this is why this stuff happens. You've got to have some background. The reason you see fade, when you do tetanus, when you do DBS, when you do train of 4, anytime you do repetitive stimulation and you see fade, what that means is the muscle is getting weaker in its response, right? In other words, if I do a tetanus, let's say I'm going to do a tetanus stimulation, which we're going to talk about here in a few minutes. If I do a tetanus, and I push that button, tetanus, 100 hertz, 1, 2, 3, 4, 5, take my finger off the button. This is what I should see. If you did it to me right now and I'm not paralyzed, this is what you should see. 1, 2, 3, 4, 5. I was wiggling. 1, 2, 3, 4, 5. No fade. The hand stays contracted. We call it sustained. the tetanus is sustained for the whole 5 seconds I'm pushing the button. All right? The reason that happens, that I'm able to sustain that tetanus, you would be able to too, is because in the neuromuscular junction, there are presynaptic and postsynaptic nicotinic receptors. And I'm going to go to my neuromuscular junction here. It's the whole reason I put the picture in here. Here's a neuromuscular junction. Here's acetylcholine receptors. You see where they said that right here? They're pointing to them. They look like these little dots. These black dots. Those are the acetylcholine receptors. All right. There's also acetylcholine receptors on the presynaptic terminal. And the way the physiological muscle function works is there's a positive feedback. You're used to negative feedback. This is a positive feedback. In other words, if I'm getting a strong stimulus, tetanus for 5 seconds, and then action potential streaming down this nerve, and it's causing the acetylcholine to release into the synapse. The acetylcholine that's released in the synapse also stimulates presynaptic receptors as well as post, and tells the presynaptic receptors, keep coming, give more acetylcholine. It's a positive feedback. Make more come out. This muscle needs a lot of strength. We need more acetylcholine. So when there's a lot of acetylcholine in the synapse, it doesn't tell the nerve slow down. We got enough. It actually tells the nerve, yeah, send more. This is great. See what I'm trying to say? So when you give a relaxant, like rocuronium or acetylcholine, whatever, and well, not sucks, but rocuronium and so on, they block the postsynaptic receptors and make you paralyzed. But they also block the presynaptic positive feedback loop. So therefore, when you give a strong stimulus and you're trying to tell the nerve to keep squirting acetylcholine out, it can't. That's why you see fade. The muscle can't sustain the contraction because its mechanism, positive feedback loop mechanism, is blocked by the relaxant being on the presynaptic receptor. So the normal thing would be a sustained contraction. But when you start getting paralyzed, you saw that train of 4, 1, 2, 3, 4, they get smaller and smaller each one, then you're starting to see fade. Because the nerve is losing its ability to keep squirting out acetylcholine, and you start to see fade. It's a sign of that, a sign of the paralysis coming. All right, does that make sense? So you gotta, the reason you see fade is because of blockade of the positive feedback loop in muscles that helps sustain muscle function. I hope I'm not being too obscure. Now, let's go to page 22. This is sucks. Trainer 4 test with sucks. This is trainer 4. Before you give drug, give 100 milligrams of sucks. Oh, look at that. That's kind of weird, isn't it? Smaller, 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 gone. Look at sucks is wearing off. 4, 4, 4, 4, 4. So, what I can tell you is this. There is no fade with succinylcholine. Succinylcholine doesn't affect the presynaptic receptors, only the post. So when you lose the twitches, you lose them all together. All 4 are the same, they just get smaller, smaller, and they're gone. Then all 4 come back together. See that? Sucks is different. What's the training 4 ratio? Well, it's always 100% with sucks. 4th is always the same as the 1st. So really, that test is meaningless. There's no such thing really as a training 4 ratio with sucks.
You say it doesn't affect pre or post?
Pre. does not affect pre. It does affect post. The SUX doesn't affect presynaptic nicotinic receptors. The non-depolarizers do, which results in fade. SUX and the non-depolarizers affect the postsynaptic receptors. Question?
So when you have a train of 4 fade with non-depolarizing drugs, would your sustain technique get weaker
Yes.
as the 5 seconds?
Yes, if I'm pushing a tetanus button, that's a good question. I was going to show you that next. If I'm pushing a tetanus button for 5 seconds, so I'm going 1, 2, 3, 4, 5. Right? And I paralyze somebody. Let's say you're 50% paralyzed with chronic. I push that tetanus button for 5 seconds. This is what you see. Oh, 1, 2, 3, 4, 5. By the time I get to 5 seconds, the hand's already relaxed back. It fades. It can't sustain the contraction. All right, I got a little movie. I'll show you that. All right. Everybody with me? Never knew you wanted to know all this, did you? Probably don't. All right, this is BVS. This is quick. We'll blast right through this. This is page 23, next page. These are the sine waves coming out of the box. That's just showing you when the box gives out juice on the top here. So what they're doing in this one, so they're doing a train of 4, then it's showing you what it would be if you do a DBS. Remember, double burst stimulation is 2 blasts of 0.7, I'm sorry, start again. 2 blasts of 50 hertz separated by 3/4 of a second. So this is starting out. You haven't done anything yet. Here's train of 4. This is DBS. They're equal. They're bigger than the train of 4. Why? Because the train of 4 is 2 hertz and DBS is 50 hertz. That's more juice. Electricity juice. All right, here comes. Recovering, they're saying here, 20% recovered. Your train of 4 ratio is going to look like this. You got 4 twitches, there's still fade. That means there's still paralysis around when you see fade. The 4th twitch is, let's eyeball it. They're saying 20% of the first. I think it looks bigger. But I probably didn't draw the lines right. This is what DBS would look like. The 4th would be about 20% of the first. Then when it got up to 40% recovery, see things, these are getting bigger, less fade, bigger, less fade, and back to normal. So DBS just follows the train of 4, same idea. They're just bigger twitches and there's only 2 of them. You compare the first and the second. You just want them to be equal. When they're not equal, then you got fade, then you got paralysis. Make sense? Let's take a break. All right, let's get started. Now, there's some issues about the positive feedback. A couple of people. Let me say it once more. And you don't have to look at this or anything, but this is page 111 in the book. Remember this figure from last year? Let's make it a little. So, remember last year we said that when you release a neurotransmitter from a nerve towards a tissue, there's a negative feedback system, presynaptic neurons. When you stimulate it, it stops more neurotransmitter from coming out. It's a way to have the signal, but then just control it. However, in muscles, it's the opposite. It's a positive feedback. What happens is, when the let's say, you give a relaxant, you're paralyzing these postsynaptics, of course. but you're also blocking the presynaptics. And what they do is they control the amount of acetylcholine that comes out. In a muscle, the more that comes out, then the more it continues to come out. Because the muscle's thinking, I need sustained abilities to keep this muscle strength happening. And as long as there's an action potential coming down, you're going to try to amplify how much comes out. When you block those receptors, and then you block the positive feedback, then the patient starts to show fade. All right, so hopefully that'll make some sense. I'll be glad to go through it again if you'd like. Okay. Now, lastly, then we're going to take a look at a movie. Post-tetanic count. Let's go to page 24. Now, before we do that, let's talk tetanus. Tetanic stimulation, or tetanus, is the strongest stimulation you can use out of the box. It's either 50 hertz or there's a button inside you can push that's 100 hertz. Most people just do 100. And you push the button for 5 seconds and the hand should stay contracted. That's a normal test. It's called a sustained contraction. It should be sustained. You take your finger off the button, it goes away. If the patient's partially paralyzed, in other words, if they're 100% paralyzed, you're going to push the tetanus button and you're going to get nothing because they're 100% paralyzed. But if they're less than 100, say 90 or 80, you're going to push the tetanus button, you're going to get the initial contraction, and then even though your finger's on the button, it's going to relax down to resting. Does that make sense? Now, here comes a question. What if the patient's 100% paralyzed? What if I get to the end of the case, and this is going to happen all the time, sometimes almost daily? What if I get to the end of the case, I push my little twitch button, and nothing? And the single twitch button, if I haven't mentioned, I should, it's kind of an all or nothing test. Either the hand moves or it doesn't. If it doesn't move, you know the patient's probably 100% paralyzed. If it does move, they're not 100% paralyzed. That's all you know. You don't know how much, what percent, whatever. Twitch is all or nothing. Either it's there or it isn't. So it's not that useful a test. So you do a train of 4. 1, 2, 3, 4 outputs in the box, nothing. Hand doesn't move. Then you do a tetanus. Push the tetanus button, hold it down, 1, 2, 3, 4, 5. Hand doesn't move. What do you know? Patient's 100% paralyzed plus some extra floating around, right? So let me use some poetic license and I'll say maybe they're 120% paralyzed, 130%, you know, which would be 100% paralyzed but 20% more drug than you need, 30%. What if they're 200% paralyzed? Enough drug in there for 200%. You don't know. All you know is you had nothing. None of these tests are working. Well, there is one possibility of a test that you can do as a post-tetanic count, where you can maybe figure out how paralyzed this person is and how much it's going to take to get him reversed. All right, and the post-tetanic count relies on this. There's a phenomenon physiologically known as post-tetanic potentiation, or some books will call it post-tetanic facilitation, or post-tetanic stimulation, whatever word they use. Post-tetanic facilitation, right? What it means is this, don't write anything down. Just, here's what happens. If you push the tetanus button for 5 seconds and you get no response, you know that you have 100% paralysis, obviously, all right? Everybody with me on that? However, that 5-second tetanus mobilized a lot of acetylcholine. So temporarily, for several seconds in the synapse, you've squirted a whole bunch of acetylcholine in there. It just, patient's 100% paralyzed, you didn't see any response. But if you go back and push the twitch button, for a few seconds, the twitch button will work. Because you have all that extra acetylcholine sitting in the synapse, and it's going to take a couple seconds for the acetylcholine esterase to metabolize it. And so during those few seconds, you can actually get a twitch response just locally in that hand, because there's so much acetylcholine in the hand that it's overcoming the 100% blockade of the drug. It's competitive inhibition. Then the acetylcholine gets metabolized and the patient goes back to 100%. It only happens in the hand, or wherever you're testing. That's called post-tetanic potentiation. That means if you do a tetanus for 5 seconds, and then after the tetanus, post-tetanic, after the tetanus, you go back and push the twitch button, you'll be able to get a few twitches while the acetylcholine is being metabolized. Then they'll go away. And if you count how many twitches you can get, that's called the post-tetanic count. And the scale is going to be anywhere from 0. If you can't get any, then this patient's really paralyzed. You can't even get the most extreme test to work. All the way up to about 7 or 8. If you get 7 or 8, they say the train of force should start working again. Now they're maybe 105% paralyzed, or about to be just 100% or 95. So you want somewhere between 0 and 8. The more you get, the less paralyzed the patient is. The more they twitch, the less paralyzed. Now, as I said, in a couple of weeks, we'll talk about Sugammadex. The Sugammadex folks are saying this is the normal dose for a normal patient that's responding with some twitches. If the patient has no twitches, or you want to hurry up and reverse somebody, the post-tetanic count is 0, then give them X number of milligrams. So they're basing their reversal dose on what the post-tetanic count is. So even though the post-tetanic count, everybody stopped doing it, now all of a sudden it's back again, and they're talking about it. So here's what happens. By definition, watch my hand. Post-tetanic count is a tetanus at 50 hertz for 5 seconds, followed by a 3-second pause, then followed by twitches. You just push the twitch button, keep pushing it. So here goes. Tetanus for 5 seconds. Ooh, nothing happened, because I'm 100% paralyzed. My hand didn't move. Take my finger off the button, wait 3 seconds, push the twitch button. Well, I got 3, and then all of a sudden I was flat again. Post-tetanic count is 3. All right, take a look at page 26. If the post-tetanic count is, say, well, let's say 0, 1, 2, 4. So let's say 4. Using intermediate relaxant, you should recover in about 4 minutes. You should start showing twitches in about 4 minutes. They're almost ready to be less than 100%. Maybe they're 110. Right, again, I know you can't be more than 100, but it's just poetic license. If you're using a long actor, you're still going to have to wait another 20 minutes before it wears back to 100%. So it's what the post-tetanic count, to summarize, it's a test you only do when the other ones don't work. Why? Well, the train of 4 will tell you 70 to 100. Tetanus will tell you 50 or less. So all those DBS tells you that. So those will tell you what percent paralyzed you are, less than 100%. If you're more than 100% paralyzed, none of those tests are working, then there's still one thing you can try, and that is you can do a PTC, do the post-tetanic count. And then count how many twitches you have, and that gives you an indication of how paralyzed you are. If the PTC is 0, call a recovery room, ask for a ventilator, bring the patient to the recovery room, put them on a ventilator. It's going to be a long time before the relaxant wears off, and you got to keep them safe. You're going to see, I'm going to repeat this a zillion times. Whenever you have a problem with a relaxant, any problem, we're going to talk about dozens and dozens of problems you can have where it's not wearing off right. The treatment is always identical. Ventilate the patient, sedate them so they're not awake, paralyzed, give them some first head and vacuum, and wait till the drug wears off. It always works, it's 100% effective, no side effects. There you go. Treatment is always easy. Don't fight it, don't try to give more drugs, don't try to be pseudo-scientific. Just put the patient on a ventilator, bite the bullet. I know it was only a hernia operation that people are going to laugh at you. Put the patient on a ventilator, keep him in the bed, it'll all wear off, everything's going to be fine. The patient will be fine. Okay? That's PTC. All right? Now, let's look at some of this stuff. I got a movie to show you. I can get it to work. Oh. All right, this is a movie that one of our colleagues here at Kaiser, two of them actually, did, and they were really nicely done, and they were gracious enough to let me try it, and so it's about 10 minutes.
The peripheral nerve stimulator is a device that delivers an electrical stimulus near a peripheral motor nerve and actually evaluates the evoked potential of the muscle or muscles innervated by that nerve. So today we are going to innervate the ulnar nerve, which will elicit a response from the adductor pollicis, which is indicated by movement of the thumb and usually the index finger. So this particular nerve stimulator comes equipped with two leads, which we'll be using today, and a ball probe, which can be inserted in here in place of the leads. So when we place the peripheral nerve stimulator leads on SAS here, we want to make sure that we place the distal lead on the actual ulnar nerve that we would like to stimulate, and then the proximal lead is about 2 to 3 centimeters above that. And normally your black lead is the negative lead,
That's a different person.
which goes distally, and your positive is your red lead, which goes proximally. And I remember that because red is closest to the heart. So theoretically, one should establish what's called initial threshold prior to administering any neuromuscular blocking drugs to the patient. So ideally, after induction, but prior to administering muscle relaxants, we want to establish an initial threshold. And we do this by using the lowest current needed to generate muscle activity. And that usually is around 3 or 4 on the dial. So we will do that right now. So I'm at approximately 4, so that is initial threshold. So ideally, we really want to have supramaximal threshold to monitor neuromuscular blockade depth. So that is usually 2.5 to 3 times your initial threshold, which generally is going to be at the dial number 10 on your peripheral nerve stimulator. So today we're going to be eliciting the ulnar nerve in order to get a muscular response from the adductor pollicis. With induction, ideally, we should be monitoring or innervating the facial nerve and monitoring the orbicularis oculi, as this is reflective of vocal cord paralysis. Therefore, when we monitor the adductor pulses, this is more reflective of diaphragmatic return, which is usually monitored with emergence. Okay, the first mode of stimulation that we're going to present is the single twitch mode. The single twitch is a single maximal twitch delivered every 1 to 10 seconds. This is primarily done on induction. So again, after induction, but prior to any neuromuscular relaxants administered, we want to go ahead and establish baseline in regards to a single twitch. So we will do that right now. So we're at supramaximal at 10. So elicit a single twitch. And we get a strong twitch. After giving our muscle relaxant, ideally we would like to see no twitches, indicating that conditions are optimal for direct laryngoscopy. So let's go ahead and deliver a single twitch after an induction dose of muscle relaxant. We get no response, therefore we are able to go ahead and do our direct laryngoscopy. The next mode of stimulation will be the train of 4. The train of 4 is the most commonly used mode of stimulation with anesthesia and analyzing adequate depth of neuromuscular blocking agents. So the train of 4 actually is a series of 4 twitches delivered at 2 hertz every half second for 2 seconds. This mode of stimulation is used during the maintenance of anesthesia and also on emergence. We are at supramaximal threshold, which is 10 on our dial, and we are going to use the train of 4 stimulation mode, which is on our peripheral nerve stimulator here, to elicit a response. So we have 4 strong twitches, thereby indicating that my patient needs neuromuscular blocking agents. So we've established that our patient does not have any muscle relaxant on board, and we can verify that again by doing our train of 4 at supramaximal threshold.
Do you want to do it again?
Yeah.
So we elicit 4 strong twitches. Therefore, I will administer a maintenance dose of non-depolarizing muscle relaxant. After doing so, I should wait approximately 3 to 5 minutes, and then I can monitor my train of 4 again to see the response. Normally, with a non-depolarizing muscle relaxant, you will see a progressive decrease in twitch height, otherwise known as fade. So let's go ahead and see if we have fade after administration of our non-depolarizing muscle relaxant. So we do have fade. So again, with a non-depolarizing muscle relaxant, we get fade, or a progressive depression of twitch height with our train of 4. However, when administering a depolarizing muscle relaxant such as succinylcholine, you will see equal depression of all 4 twitches. The next mode of stimulation is the tetanus mode. The tetanus mode should be used sparingly, as it is very painful to the patient. It is a continuous current of 50 to 100 hertz, and in some models it can deliver up to 200 hertz for approximately 5 seconds. This is primarily used on emergence to detect fade. So a normal response with tetanus without any neuromuscular blockade drugs on board should have no absence of fade. There should be strong contraction, or what we call tetanus. So we are at supramaximal threshold, and I'm going to elicit a tetanus for 5 seconds. And as you can see, we have a strong contraction without fade. So in emergence, our patient has non-depolarizing muscle relaxant in their system, and I have reversed my patient with the train of 4. I'm eliciting some fade. However, I want to verify that with the tetanus response. So I'm at supramaximal threshold. I want to assess for fade. Ideally, I should not have any fade. So supramaximal with non-depolarizing muscle relaxants. So it's been 5 seconds and I've delivered that shock, and we do have fade. So in this particular peripheral nerve stimulator, in the back of it, we can check to see where our hertz are at in regards to delivery of our tetanus, 50 hertz or 100 hertz. And generally you will find it at the 100 hertz. The next mode of stimulation will be the double burst mode. The double burst is 2 short tetanic stimulations of 50 hertz separated by 0.75 seconds. And we're really evaluating the second tetanus to the first. So without any muscle relaxants, we should have 2 strong twitches in our double burst stimulation. And we do. In the presence of a non-depolarizing muscle relaxant, there should be fade with double burst stimulation. Double burst stimulation may be easier to detect fade more so than the trainer 4. So we'll be comparing the first twitch to the second twitch, and we have administered our non-depolarizing muscle relaxants. So let's take a look at double burst with fade. The last mode of stimulation that we're going to cover is the post-tetanic count. So this is actually used when there is profound neuromuscular blockade and there is no response to trainer 4 or double burst, or in some instances, tetanus. So post-tetanic count actually is the delivery of a tetanus of 50 hertz for 5 seconds. There is then a 3-second pause, and then 10 single twitches at 1 hertz are then delivered. The anesthesia provider then counts the number of twitches that are elicited in those single twitches to indicate a probable time of recovery and eliciting a response in a trainer 4. SAS was administered non-depolarizing agents. The surgery ended abruptly, and I was not able to elicit a response on our trainer 4 or our double burst. Therefore, I'm trying to figure out, when can I actually reverse this patient? When will I get a single twitch back on my trainer 4? So here's a normal response with post-tetanic count when there are no neuromuscular blocking drugs administered. We will deliver a tetanus at 50 hertz for 5 seconds. 1001, 1002, 1003, 1004, 1005. We'll then have a 3-second pause, and then we will deliver single twitches, 10 of them. 1, 2. We do get sustained tetanus, and we have 10 twitch responses. Therefore, I should have a response on my trainer 4. In the presence of profound neuromuscular blockade, where the anesthesia provider cannot elicit a response from a trainer 4 or double burst, we need to estimate the time required for muscle contraction to come back. Therefore, we will perform the post-tetanic count. We will deliver a tetanus at 50 hertz for 5 seconds, followed by a 3-second pause, and delivering 10 single twitches thereafter, making sure that we count the twitches that we either see or feel. So here's our tetanus. 3, 5. So we do not get a response on our tetanus. We have a 3-second pause, and then we will deliver 10 single twitches. So out of the 10 twitches, we were able to elicit 4 responses. This is a rough estimate that when using an intermediate non-depolarizing muscle relaxant, that there may be 10 to 15 minutes before I'm actually able to get a single twitch on my trainer 4 count. So in closing, the most commonly used modes of stimulation are the trainer 4 and the tightness. Obviously, these are very subjective, the tools that we use, and we have to keep in mind that we still need to look at our extubation criteria before determining if it is safe to extubate our patient.
Ta-da.
Hi, I'm Sandy Bordy, and this is my assistant, Sass Elisha. I'm going to talk to you today about the peripheral nerve stimulator and...
As you can see, if you want to see the movie, it is on my website, right on the page with Sandy's nice enough to let me use it. And it's just on the page with under resources. So I know some people said it's hard sometimes on the recording to see the embedded ones. So if not, you can watch it separately. So anyways, let's kind of summarize for a little bit. We can use a nerve stimulator to help us determine the percent paralyzed somebody is within reason. We're always wondering percent paralysis because we want them to be 0% when we take the patient off to PACU. And so how can we tell? Well, single twitch. If they twitch, they're less than 100%. If they don't, they're 100% or more. That's all or nothing. Train 4 will tell us between 70 and 100. If they evolve to 4 twitches and the ratios, they're all looking pretty much the same, they're 70% paralyzed or less. If they have 1 twitch gone, they're in the 70s, 2 twitches 80s, 3 twitches 90s, 4 twitches gone, they're 100% paralyzed. The tetanus, most juice that comes out of the box, the strongest response we can elicit. If there's fade, the patient's still paralyzed. If there's not, it's returned to normal. And finally, when we're all out of ideas and patient's paralyzed and the case is over, we want to know how long I'm going to have to wait, or at least some response to happen with the regular tests. You can do the PTC, and the lower the number, the more paralyzed the patient is. So if you get a post-10 count of 2, call PACU and get a ventilator. If you get a post-10 count of 7, they should start showing the rule is generally the first twitch and the train of 4 returns once you get to 8 PTC. So if your PTC is 8, the train of 4 test should start working. Which means, of course, that you're not above 100% anymore. Then you can go ahead and reverse. So the scale is from 0 to 8. Okay? Now I know it's a lot of anesthesia flim-flam, but it's important to know and have an understanding of. And it just takes a little practice. You can start to differentiate strength of 1, 2, 3, 4, etc. Feel the patient's hand, watch it. When you're sitting there with nothing to do and you're tired of listening to the surgeon droning on about whatever they drone on about, then you can play with your little box underneath the drapes. It'll kill the time. Try to keep your instructor from asking you questions. And make it look like you're really busy assessing this patient. I'm doing a total H&B here. Twitch, twitch, twitch. Now let's go to page 26. We're about to page 26 is a little thing that you're going to memorize, because I'm going to ask you this on the first test. I memorized it. Everybody memorized it. You're going to memorize it too. It's important for a reason you'll see. Everybody needs to know this. So here we go. When you do neurostimulator tests with succinylcholine, which is the only depolarizing drug, we refer to succinylcholine block as being a phase 1 block. That's just the terminology. We refer to a non-depolarizing drug, any of them, non-depolarizing block, as a phase 2 block. Because of characteristics in the EMG lab and they do muscle studies, you know, who cares about all that? So a SUX block is called a phase 1, and a non-depolarizer is called a phase 2. What's the difference between these two? You're barrelized with both, right? We'll talk about SUX next week in great detail. But number 1, look at the bottom of page 26. Characteristics of neuromuscular blockade, and you're going to memorize this, so put a note next to it. Phase 1 or a depolarizing block. Number 1, first bullet. You get muscle fasciculations that precede the onset of the neuromuscular blockade. The patient's muscles all twitch when you give a depolarizing drug like SUX. Why? Because it's depolarizing the muscles. And they'll all contract once. And you'll see the wave of fasciculations occur where the drug gets to first to where it gets to last. So they'll start in your face, head and neck, chest, abdomen, all the way down to your toes. If you pull the drapes off somebody and they're just lying there naked and you give them SUX and watch where they fasciculate, don't pre-treat them. It'll be in the face and it'll end up in their toes. That's just a matter of drug distribution. That's where the drugs gets to and when, right? The longest place to get to is your toes. It's the last thing to move. So you get muscle fasciculations. You get a sustained response to tetanus. So I can't look for tetanic fade when I'm checking a SUX block. It's always sustained. The SUX doesn't affect the presynaptic receptors. There's no post-tetanic potentiation, stimulation, facilitation, whatever. That means I can't do a post-tetanic count if I'm doing SUX. There isn't any. There's no fade to the trainer 4 or to the DBS. So there's just no fade, period. Everything's sustained. They all go out together, they come back together. I showed you that, didn't I? Second last bullet. The block is antagonized by prior administration of a non-depolarizer as pre-treatment. So this is funny. They're telling you to look for when somebody fasciculates and all their muscles contract once, because it's drug-induced and not natural, people feel that what happens is muscle fibers next to each other don't contract synchronously. They just contract according to where the drug gets first. And that can do little micro tears in the muscles, not visible, but they're there. And so the next day when they wake up, you have muscle pain. And we'll talk about it next week, fasciculation pain. But it's more common in healthy people, usually women more than men. But you wake up the next day and you feel like you went to the gym for the first time in 3 weeks, and the next morning you wake up and you're real stiff and you can hardly move. And it takes a little bit to kind of get up and moving. That's how you feel. So we just played the surgeon and move on. Oh, I don't know what that surgeon did. Oh my. So in order to prevent or minimize the amount of fasciculation-induced pain, you can give a small dose of a non-depolarizer. Prior to the SUX, they don't fasciculate as strongly. They still fasciculate, you don't see it. And so they'll have less pain. It doesn't make it all go away, but it certainly minimizes it. Why not? What's it cost you? Nothing. Give them a CC or something. Hopefully the pain will be less. Did they teach you to do that? Pre-treat? Now you would think, I have a point. You would think that if you gave a small dose of a non-depolarizer, then you followed with SUX after the propofol, that you'd have to give less SUX, because I just gave a CC of non-depolarizing. Alright, they're a little relaxed, right? But they actually antagonize each other. The non-depolarizers antagonize SUX. This is what they're saying. Look at my second last bullet on page 26. Block is antagonized by prior administration of a non-depolarizer as pre-treatment. approximately 20%. So if you don't pre-treat somebody, you can intubate with about 60 milligrams of sucks, pretty routinely. 60 to 70. When you pre-treat, you only got to bump it up to 90, 100. All right, the easiest thing to do is what? Just give 100 to everybody for the rest of your life. Why mess around? Just give 100, it'll work. Why try to figure out the dose? There is no figure. Succinylcholine, you just give 100 milligrams. All right, next. Don't have any drug errors. You'll know exactly how much you're giving every time. That'll work. When you first start to intubate, maybe somebody will work with preceptors, and they'll say, let's give 120. Do you ever work with something like that? What they're doing is they're nervous that it's going to wear off before you'll be able to get that feedback. And they just don't want to have to go home with a headache, so they're making it try to get a little last longer. Just kidding. All right, then finally, the last bullet here is the phase 1 is sucks block is potentiated by neostigmine, by cholinesterase. Succinylcholine is broken down by cholinesterase. If you inhibit cholinesterase, guess what? Sucks isn't broken down. So the block is potentiated by giving neostigmine. You just remove the enzyme required to break it down. So if you give somebody sucks, you can't reverse the neostigmine or cigarettes. All right, let's look at phase 2, a non-depolarizer. There's no fasciculations when you give rocuronium or any of the non-depolarizers because they don't depolarize the muscle first. You have tetanic fade, post-tetanic potentiation, trainer 4 fade, DBS fade. You got fade everything. Everything fades. You can reverse it with neostigmine, anticholinesterases. And if you produce an overdose of sucks greater than 6 milligrams per kilo, you can possibly start to see some phase 2 characteristics. Just wipe that out, nobody cares. We never give that much anymore anyway. In the old days when I trained, we used to use sucks drip. Big liter bag of sucks infusion, and rather than give a non-depolarizer, because we didn't have any, then we would use sucks for 3 or 4 or 5 hours, drip it out of a IV bag. And by then you end up giving 10 milligrams per kilo, and then you couldn't reverse the patient because they were subparalyzed. And that used to be a big issue. Nowadays, that only happens when you get, look at it says, above 6 milligrams per kilo. Well, you could be the worst intubator on earth, and you're not going to get above 6 milligrams per kilo. Let's say it's a 70 kilo person, and it's 6 milligrams per kilo. That's 420 milligrams of sucks. That means you had a miss, go back, gives more sucks, miss again, go back, give more sucks, miss again. You have to do that to get 420 milligrams. That's going to be about an hour later by the time you get up to that much. So it's not going to happen in the real world anymore. We don't use sucks strips, so you can forget it. Okay, well, welcome back. See you next week.